Thanks, David. Okay, we do have the slides. Now that you're all whipped up into a frenzy of enthusiasm to take this out into the clinical realm, I think we need to take a step back and discuss kind of what's required before you do that. And that's my job, is kind of discuss implementation of notes into clinical practice. Let's see how there we go. So we know that it has made the transition from animal into human studies. I'm sure you're all aware that all over the world now there's notes cases going. There's probably as many as 200, possibly even more cases that have been done. And I think a whole range of things have been done, in fact, and probably undoubtedly by this time more things than we had. And I just heard 2 days ago that even a transvaginal colectomy for cancer has been done. So the cat's out of the bag, and things are in the clinical arena at this time. And I'm sure many of you wouldn't be here unless you were at least intrigued by the idea of bringing this into your practice. So let's talk about where we go. And I think one of the things is caution about this. You may be a little bit pushed into doing this by your patients. We don't know yet, but there's some indication that patients may be enthusiastic about notes. This is from a survey that we did of patients' attitudes towards notes, telling them if you were going to have your gallbladder out, would you have it done laparoscopically or by notes? And as you can see, the majority of patients would prefer notes. And I think what's very interesting with this is they would prefer it even if there's a higher complication rate. So I think as surgeons, we kind of figure that we won't be hearing a lot about this from our patients because of fear of complications. But patients look at things differently, and you may get pressure to start practicing this earlier as opposed to later. And to kind of cite this oft-cited truism, those that cannot remember the past are condemned to repeat it, I want you to hearken back to the early days of laparoscopic cholecystectomy, and this is Eric Muhe, and I think most of you know his story. He was the first one really to do laparoscopic cholecystectomy as we know it, and he was soundly condemned, and his life was essentially destroyed by complications he had. And even though he brought us a wonderful gift of cholecystectomy, it's difficult to be a leader in this, so a little cautionary note. So let's talk about it a little bit, because terminology is important in this, and let's ask if notes is investigational or not. And I think, as you heard earlier today, obviously it's an investigational procedure. Nobody really has a definitive answer as to patient benefit in this, so I think that certainly falls in the category of investigational. I think a real question, and one you'll get asked by your IRBs, is it experimental? And I think at this point, obviously, it's in the clinical arena, and it is not an experimental procedure. The experiments happened in the lab. They've happened over the last 4 years by many of the innovators you've heard of, and this is no longer an experimental procedure. We're not experimenting on humans. We're investigating its application. I think most of you have heard of NOSCAR as an organization sponsored by ASGE and SAGES that's trying to bring some collaborative framework to doing this. And I mention this because they're really the group that we're looking to publish guidelines and give us some sense of where we need to go in our own practices with this. And I'll just run through the mandate of NOSCAR. Many of you know, sponsoring research efforts, creating and maintaining an registry, organizing meetings, defining the field, and creating various publications. But NOSCAR very strongly came out and said, as part of their practice guidelines, that notes should only be done under a strict IRB protocol. So the governing body that's trying to bring order to notes and maintain patient safety and everything certainly insists that for the foreseeable future that you should absolutely have an IRB to do this. And as we know, there's a lot of regulations besides IRB, but IRB is really your final line of defense for patient care. So even though the others weigh in, they tend to weigh in late, and each institution really has the final say of whether you're going to be able to do this or not. I think it's been stressed that you should not go into this without adequate laboratory experience. So the first one is you have to establish a firm basis of laboratory studies. And I'm going to kind of use our own experience. We have a human IRB, human study IRB, and talk to you a little bit about that because it shows the process of doing it. So we essentially spent 10 years in the lab working on various endoluminal and then extraluminal research projects, going through basic science, animal studies, and then up to cadaver studies until earlier in 2007, we did our first human notes patient after dozens of survival animals, lots of cadavers, and adequate preparation, and under an IRB protocol. So at the end of all this, earlier in 2007, we did do an IRB submission for a phase 1 outcome study. It surprisingly went through our IRB committee quite rapidly. Typically, it's something like this would take 6 to 8 months to get through the various revision process. But the IRB committee was notably excited about this. And IRB committees are composed regularly of community people as well as physicians. So they were excited about it, and much to our surprise, we actually was approved after only 3 revisions and approved in May 12th, and we did our first patient under the protocol on May 31st. Nat Soper and his group at Northwestern then joined us in a collaborative protocol so we could speed up the accrual. Now, this is a list of one of the final lists that the IRB committee gave me, asking questions about our Human Notes IRB. And it's a little bit hard to read, but it was just interesting to see their perspective. They were concerned about the ability to check bleeding. They were concerned about the security of our gastric closure. They were concerned about the ability to have a fallback thing, which obviously would be laparoscopic fallback if we weren't making progress or if something was happening. And they were wondering what the absolute risk-benefit ratio was for patients. How much more risky was this for patients based on our animal studies? And they were also interested in what would happen during passage of scopes and withdrawal of organs through the esophagus, which I thought was interesting. So stipulations that we came up with our RRB was, these were given to us by the RRB committee, is that we use no experimental equipment, nothing that wasn't FDA approved, that we have a minimum of 1 laparoscopic port to confirm the integrity of the gastric closure and the absence of liver bleeding, because once you pull that scope back into the stomach, you really can't check the gastric closure or make sure you're not bleeding. They also insisted that we have liberal use of additional laparoscopic instruments as needed for patient safety. And obviously, we're expected to give individual case reports to the IRB of our first 10 patients. So that's where we were. That's how our IRB process, and I think most of you would be faced with the same process as you go. So I think my conclusions, Mr. Chairman, is that NOTES is an investigational procedure at this point. Human cases should absolutely only be done after extensive experience in the laboratory with animals and preferably cadavers, and that obtaining IRB approval is mandatory for patient safety and to protect the surgeon. And I'll conclude with this little snippet here. Our phase 1 study has actually been somewhat shut down because the insurance companies are refusing to pay for it. And as you can see in this denial form from one of our local insurers, the use of laparoscopic transgastric cholecystectomy for the treatment of biliary colic is considered to be both experimental and investigational and unproven, and we're not going to pay for it. So I think that's the other thing, is even if you have your IRB approval, there's other hurdles to jump, and you need to be forewarned about that as well. Thank you very much.